Hello?
Okay, great. All right, so we'll go ahead and get started. Good afternoon, everyone. My name is Jarian White, and I'm a PGY1 pharmacy resident here at Ochsner LSU Shreveport. And my title of my presentation is Bump in the Road, Exploring Pregnancy-Associated Complement-Mediated Hemolytic Uremic Syndrome. As far as disclosures go, I have nothing to disclose in relation to this presentation. Moving on to objectives, by the end of this presentation, pharmacists should be able to review the pathophysiology of thrombotic microangiopathy, or TMA, distinguish complement-mediated hemolytic uremic syndrome, or CMHUS, from other TMAs with similar clinical presentations, be able to recognize signs and symptoms of pregnancy-associated CMHUS, as well as discuss the management and treatment for pregnancy-associated CMHUS. For pharmacy technicians, they should be able to describe the symptoms of CMHUS, be able to recall how pregnancy can trigger and exacerbate this disease state, as well as list the medications used in the management and treatment of pregnancy-associated CMHUS. First, we're going to go into a brief overview of CMHUS. So what is CMHUS? It's a type of thrombotic microangiopathy, or TMA, that can occur during pregnancy and postpartum. It was formerly known as atypical HUS or AHUS. So if you hear me use those interchangeably throughout this presentation, it's because it was a recent change, and some of the studies that I present do refer to it as HUS. So for CMHUS, there are three main components. Patients with this disease state will experience severe renal failure, as well as hemolysis and thrombocytopenia. I would like to emphasize that TMAs are a medical emergency. They can lead to death if they are not treated. So patients with TMAs will present with microangiopathic hemolytic anemia. So these hemolysis markers that you would see would be increased LDH, increased indirect bilirubin and reticulocytes, as well as decreased haptoglobin. You will also find that your patients may present with thrombocytopenia. And so this is basically because of your platelets, they're constantly clumping together and they're forming these small clots in your small vessels. And overall, this is going to cause ischemic and organ damage. So I just mentioned that those small clots being formed are causing those small clots that are being formed in your small vessels are causing these in-organ damages that can occur. So all your systems that have vasculature. So in addition to severe renal dysfunction, you can also experience cardiovascular complications such as MI and VTE, some GI complications, as well as neurological complications such as stroke and seizures, as well as pulmonary and vision complications. As I mentioned previously, your platelets are clumping together, forming these tiny clots in the microvasculature. And so because of this, your blood cells are getting hung up on those tiny clots, and they are having a hard time flowing through. And eventually, these red blood cells will start shearing and forming what you see here on the slide. Those are known as schistocytes. Schistocytes are a nonspecific indicator of hemolysis, so they can be seen in other disease states. You can see these in patients with mechanical heart valves, hematologic malignancies, patients on dialysis, cancer patients, as well as neonates. Moving on to the pathophysiology of this disease state. So basically it is a dysfunction in the complement cascade. And so your complement system is a part of the innate immune system, which is your body's first line defense against pathogens. So as you can see here on the screen, there are three pathways of the complement system. You have the classical, the lectin, and the alternative pathway. So in the normal patient, your alternative alternative pathway, it's maintaining a low level of activity. However, in patients with CMHUS, there's going to be an uncontrolled activation of this alternative pathway, which will lead to an overamplification of your immune response. And this, in turn, is going to lead to those clots being formed again all over your body. Going into epidemiology for this disease state, estimated incidence of this disease state is 1 to 2 cases per million per year, so it is very rare. 50 to 70% of diagnoses are caused by genetic mutations in the complement system. More than 50% of these patients will proceed to end-stage renal failure or death if they're not adequately treated. And 70% of initial presentations are associated with triggers. So speaking of triggers, I have some listed here on the slide. So this disease state can be caused by inflammation, medications, cancer, maternal fetal hemorrhage, preeclampsia, infection, as well as family history. And of course, for the sake of this presentation, I will be focusing on pregnancy. Before we move forward, I would like to introduce the first knowledge check. Which of the following is not a usual presentation of CMHUS? A, hemolysis. B, increase in serum creatinine. C, leukocytosis. Or D, thrombocytopenia. Y'all are correct. So it is C, leukocytosis. Again, I mentioned the big 3 in the beginning of this presentation. So you're going to see hemolysis, severe renal dysfunction, as well as thrombocytopenia. Moving on to pregnancy-associated CMHUS. So the diagnosis of this disease state relies on exclusion of conditions with similar presentations. So there is no universally available biomarker. And so this disease state does typically occur postpartum. So I just mentioned that this disease state is a diagnosis of exclusion. So here I have other disease states that can present with similar presentations. So under the TMA, I have TTP, HUS, and so forth. First and foremost, we'll go into TTP, or thrombocytopenic purpura. So TTP is caused by a deficiency in your ADAMTS13 enzyme. And so basically this enzyme is responsible for regulating blood clotting. It is responsible for cleaving your von Willebrand factor chains into smaller chains. And so when you have a deficiency in this enzyme, of course, as you can see on the slide, it's not going to be cutting those. And eventually this deficiency is going to lead to thrombosis. Is diagnosed by looking at the ADAMTS13 activity in your patient. And so if the percentage is less than 10%, then you can confirm that your patient is deficient in this enzyme, and you can confirm that they have TTP. Now, if it's higher than 10%, you can go ahead and exclude this disease state and move on to other similar presentations. So now that we've excluded TTP, if your ADAMTS13 activity is higher than 10%, we can move on to secondary causes of TMAs. Here I have a list of some secondary causes of TMAs. So first is HELP syndrome, also known as hemolysis, elevated liver enzymes, and low platelet count syndrome. And so I will be specifically focusing on this one because it can occur during pregnancy and postpartum. But for completeness sake, I do have other disease states and causes such as preeclampsia, autoimmune diseases, malignant hypertension, infections excluding Shiga-toxin-mediated HUS, which we will also be getting into, as well as medications such as quinine, antimicrobials such as Bactrim and penicillin, chemotherapy agents, immunosuppressants, and drugs of abuse such as cocaine and ecstasy. So that brings me to a study that compared the presentation of HELP syndrome in comparison to AHUS in the postpartum period. And so basically with HELP, is in the name, you're gonna be experiencing hemolysis as well as elevated LFTs. And so with this disease state, your symptoms generally improve within 3 to 4 days postpartum after delivering your baby. However, in AHUS, if it's not adequately treated, like I said before, you're gonna continue to progress to severe kidney failure and eventually end-stage renal disease. So with AHUS, because it's not being treated, just because you've had the baby, it doesn't mean that it's gonna go away. And so ultimately, this study found that severe elevation in serum creatinine as well as LDH levels are very specific to AHUS. So that brings us back to our diagram. We're going to rule out secondary causes of TMA, such as HELP with your persistent severe renal dysfunction. And now we can move on to Shiga toxin-mediated HUS or STHUS. STHUS is also known as typical HUS, and so this is a GI infection that can be caused by Shiga toxin-producing E. coli. And to diagnose this disease state, you're going to be looking at E. coli isolates and/or Shiga toxin detection in your patient's stool. And so I know we might typically think that this may be treated with an antibiotic. However, this disease state is managed with supportive care. So once we've ruled out all 3 of those disease states, TTP, secondary causes, as well as your Shiga toxin mediated with the negative culture, we can confirm that your patient has CMHUS. In this disease state, it occurs in 1 in every 25,000 pregnancies, so again, very rare. Up to 20% of these diagnoses are triggered by pregnancy, and around 80% of these diagnoses occur postpartum. Patients with this disease state will again present with severe renal dysfunction. So like I stated previously, if they're not adequately treated, it can result in death or just end-stage renal disease. Along with that, you will also see thrombocytopenia, hypertension, nausea and vomiting, as well as abdominal pain. So now that we've looked at your clinical presentation, I do have a case presentation for you all. So we have SM, who is a 19-year-old female who admitted to the labor unit for delivery on February 14th. She was able to deliver her baby via C-section with no complications 2 days later on the 16th. And so she was discharged from the hospital 4 days later with intermittent hypertension and nausea postpartum. And when she presented to her OB clinic the next day for a follow-up appointment, she presented with complaints of nausea, headache, and shortness of breath. She also had some concerning lab values on her CBC and her CMP. And so because of this, her OB had her admitted for suspected HELP, and she was admitted on the same day to that hospital. So like I just mentioned, she did have some abnormal lab values when she presented to the clinic for her follow-up appointment. So as you can see here on the 15th, before she had the baby, her lab values are looking pretty normal, nothing crazy or screaming at you at this point. And then on the 16th, she was able to give birth. And then on the 21st, when she presented to the clinic, that's when you start seeing the abnormal lab values. So first and foremost, you can see that her hemoglobin is low. This can be a sign of hemorrhage. However, she does have some signs of hemolysis going on. So she does have a high LDH. It's close to 4,000, which is pretty high. And then along with that, she also has a high retic count, as well as low haptoglobin, like I mentioned prior. Along with that, she's also experiencing some severe thrombocytopenia. So her platelet count at this point was 13. And as you can see, just a few days prior, it was at 257. And in addition to that, you can also see, this is probably the thing that screams at you the most, is the persistent renal dysfunction. And her serum creatinine is steadily trending up. So you can see her baseline is around 0.9. And on this day, it got up to 4.4. And it just continually increases throughout her admission. Another thing to note here is that I did mention that these patients can present with hypertension. So as you can see here, her lab value, her hypertension, her blood pressure is not crazy high, but it is higher than what her baseline was a few days prior. And in addition to that, you can also see that she has schistocytes that were seen on her peripheral blood smear. And so again, this isn't a specific indicator of this disease state. However, when you look at those schistocytes in combination with all these other lab values, that's also very indicative that she's having a TMA going on or CMHUS. So going through our diagram and our diagnosis of exclusion for SM, so we all know that she's having a TMA going on. On the 21st, she was able to get an Atom TS13 enzyme test done, and it was 72%. So as you can see, well over 10%. So she's not deficient in that enzyme. Moving over to secondary causes, we know that she wouldn't have had help. This is what her OBGYN clinic thought that she had, and that's why she was admitted. However, she did not have severe liver dysfunction, and she had persistent severe renal dysfunction, as you could see. To rule out the Shiga-toxin-mediated HUS, there was no diarrhea, unfortunately, to even do a stool culture for this patient. But I think that's also indicative that she wasn't having this disease state either, because like I said, this is a GI infection and patients typically present with a lot of diarrhea. So once they received those results for your Atom TS13, because that did have to get shipped out, they received the results 3 days later. And as you can see, she wasn't deficient again. So they were able to determine that she had CMHUS. So now that we've seen a patient with this disease state, let's look into how we would treat them. I mentioned in the beginning that this disease state is a dysfunction of your complement system. So of course, you're going to want to treat with anti-complement therapy, such as C5 inhibitors. And so the way that C5 inhibitors work is that they bind to the complement protein C5, and this is going to prevent cleavage of C5 into C5a and C5b. All in turn, this is going to inhibit the formation of complex C5b9, and then eventually this is going to help prevent CMHUS. So here on the slide, I have eculizumab and ravulizumab. Those are the two C5 inhibitors that are currently on the market. And so as you can see here, going back to our diagram from earlier, they're working right here on the C5 enzyme, and they're inhibiting that enzyme and preventing it from cleaving off into C5a and b. And in turn, it's going to prevent CMHUS again. With anti-complement therapy, of course, there are going to be some adverse effects. So here are some of the side effects that you can see with these medications. I won't go into all of them, but I would like you to know that up to 50% of these patients do present with a headache. Up to 35% of them can experience anemia. Up to 33% can experience abdominal pain, and up to 40% can experience upper respiratory tract infections just from these medications. Moving into warnings and precautions. So there is a warning for life-threatening meningococcal infections, as well as increased risk of other infections and infusion reactions. As I just mentioned, there is a warning for increased risk of meningococcal infections, the life-threatening. So this does come with a box warning. And so because of this, patients must receive a complete meningococcal vaccine series at least 2 weeks prior to the start of anti-complement therapy. And you want to make sure that they're getting serogroups A, C, W, Y, as well as serogroup B. That brings me to my next knowledge check. Patients may not start anti-complement therapy until they have completed the meningococcal vaccine series. True or false? You're saying true? Any false? You are correct, it's false. And let me tell you why. So with these medications, like I mentioned, you will want to make sure that they get their meningococcal vaccines. But what about our patients who haven't had their meningococcal vaccines 2 weeks prior? We wouldn't want to delay therapy and not give them these anti-complement therapy, give them their anti-complement therapy. So of course, we're still going to start treatment and we are going to give them their vaccines. Along with the vaccines, they are going to receive meningococcal prophylaxis as well. So with antibiotic prophylaxis for these patients, the most preferred antibiotic for prophylaxis is penicillin V, 500 milligrams oral twice daily. Some studies may suggest amoxicillin or azithromycin, as well as Cipro. You can also use the azithromycin or the Cipro if your patient happens to have a true penicillin allergy. You would want to continue this antibiotic prophylaxis until 2 weeks following the completion of the vaccine series. However, some providers may choose to still continue the prophylaxis throughout the duration of their treatment with the complement inhibitor therapy. So again, because of the life-threatening risk of the meningococcal infections, this comes with a REMS program with both of these medications. Both of these medications are owned by the same manufacturer, so they do have a joint REMS program. And with this REMS program, providers must become certified to prescribe. Pharmacies and healthcare settings, they must become certified to dispense. And along with that, they can't just order the medication and have it shipped out. You must send the company the patient's name, their date of birth, as well as the provider's name before the company will even ship it out to you so you can have it on stock in your shelf in your pharmacy. Along with that, we as pharmacists must be able to access the patient's vaccination status for up-to-date vaccines, as well as see if they're on antibiotic prophylaxis if their vaccines aren't up to date, and we should be able to document this. And also, we must be able to obtain authorization before dispensing the first dose, 6 months after the first dose, and thereafter. So that brings me to our first C5 inhibitor, eculizumab, or brand name Soliris. So with eculizumab, it does have an induction and maintenance phase for dosing. For the induction phase, it's going to be you're going to give your patient 900 milligrams IV weekly for 4 doses for the first 4 weeks. And then after that first 4 weeks, you're going to move into your maintenance phase, and then your patient will get 1.2 grams IV at week 5. And then every 2 weeks after that, they will continue to get that same dose. Another thing to note with this medication is that it is infused over 35 minutes. One thing to note with eculizumab is that it does have FDA-approved biosimilars. So right here, as you can see, it's Episcly, which was approved earlier this year in July. With Episcly, since it's a different manufacturer, it does come with its own REMS program. If there's a different manufacturer, you have to have your own REMS program. Another biosimilar is also Bekimv, which was also approved earlier this year, and this was approved in May. And so again, this is a different manufacturer, so it is going to have its own separate REMS program. And one thing to note with Bekimv is that this one is interchangeable. So because of that, if you happen to have this medication on the shelf in your pharmacy and a doctor sends over a prescription for eculizumab, you'll be able to change it to this biosimilar without even having to contact the provider to get permission to do so because it is interchangeable. Moving on to eculizumab and its use in pregnancy and postpartum. Eculizumab does cross the placenta. However, it is detected in low levels in the newborn plasma, and there has not been any effects studied on neonatal complement activation. As well as with breastfeeding, you will see some levels in the breast milk, but again, they're very low and undetectable. So overall, there have not been any adverse effects reported in neonates. That brings me to another study that looked at the use of eculizumab in pregnancy-associated AHUS. And so this was a multi-center retrospective cohort. And so one thing about this study is that this was a retrospective study that was done over 30 years. So things might have changed between now and then. I'm sure things have changed between now and then. However, it's the same concept. They had patients with this disease state that they treated with eculizumab. So they had 22 patients total who presented with pregnancy-associated CMHUS, and of those 22, 10 of these patients received eculizumab for treatment. For primary outcomes, they looked at hematologic and renal responses, and they defined hematologic response as the normalization of platelet count and disappearance of all markers of microangiopathic hemolytic anemia. And they also defined renal response as the recovery of renal function, 25% more reduction in serum creatinine levels in 2 consecutive measurements for 4 or more weeks. For secondary outcomes, they looked at if your patient basically proceeded to end-stage renal disease diagnosis. As far as the results go for the treatment arm that received eculizumab, all 10 patients achieved hematologic and renal response. 30% of these patients required dialysis initially, however, their renal function was able to recover, and 0% of these patients reached ESRD. So overall, this study concluded that eculizumab was shown to be safe and effective in reversing severe renal dysfunction prognosis in pregnancy-associated CMHUS. That brings me to our next C5 inhibitor, ravulizumab, or brand name Ultomiris. As you can see here on the slide, ravulizumab comes in 2 different vial sizes, unlike eculizumab. This one comes in 300 milligram per 30 ml vial, as well as 1,100 milligrams per 11 ml vials. And one thing to note here with this medication is that it is very long acting. It does have a half-life of around 52 days. And because of this, it is dosed less frequently, which we will get onto in the next slide. And also along with that, it does have weight-based dosing. So the dosing for ravulizumab is similar in the sense that it does have an induction phase and maintenance phase, just like eculizumab does. So for the induction phase, you will get a runtime loading dose. And then once you get that loading dose, you'll move to the maintenance phase 2 weeks following that loading dose, and you will get your maintenance dose every 8 weeks. So definitely less frequent than eculizumab. In the maintenance phase, you're getting it every 2 weeks. With this medication, you're getting it every 8 weeks. So here I have the weight-based dosing chart for this medication. So let's say you have your average patient that weighs like 80 kilos or so, you would load them with 2,700 milligrams for their loading dose, and then 2 weeks later, you will start them with their maintenance dosing with the 3,300 milligrams, and they would get that every 8 weeks. Moving on to ravulizumab and its use in pregnancy and postpartum. Unfortunately, there is no clinical data on its use in pregnancy. However, there are current ongoing recruitment for future studies. And then also there is very limited data on its use postpartum. That brings me to a study that looked at the use of ravulizumab in patients with pregnancy-associated AHUS postpartum. This was a phase 3 single-arm multi-center study, and it looked at 8 patients total who presented with this disease state who were treated with ravulizumab. For their primary outcome, they looked at the complete TMA response through an initial evaluation period of 183 days. They defined the TMA response as platelet count normalization, LDH normalization, as well as a 25% or more improvement in serum creatinine from baseline. They also looked at secondary outcomes such as time to complete TMA response, change in hematologic variables such as platelets, LDH, and hemoglobin, change in eGFR, as well as dialysis requirement status. And they define dialysis requirement status as needing to receive dialysis within 5 days of initiating ravulizumab. For the results, 7 out of the 8 patients did achieve TMA response. As far as the one patient that didn't achieve TMA response, they did achieve TMA response on day 8, so like the next day, and so they were able to improve also. So overall, this study concluded that ravulizumab was safe and effective in women presenting with this disease state postpartum. That brings me to our last and final knowledge check. Which C5 inhibitor has a longer half-life and is dosed every 8 weeks during the maintenance phase? A, ravulizumab, or B, eculizumab? You are correct, it is A. So again, ravulizumab is the one that has the half-life that is around 52 days, and in the maintenance phase, it is dosed every 8 weeks in comparison to eculizumab, which is dosed every 2 weeks. So now that we've talked about treatment, we can go back to our patient SM. As you can see here, she did start treatment on the 24th, which was the day that they confirmed her diagnosis. She also started her meningococcal vaccine series on this same day since she wasn't up to date. She did receive prophylaxis, which I'll go into more detail about in the next slide. As you can see here, oh, and also one more thing to note is that she did receive dialysis. And so she received dialysis on the 1st and the 2nd, and she also received dialysis on the 5th, which is not shown here. So as you can see, within a week of starting that eculizumab treatment, her platelets are starting to trend up. They're trying to normalize, as well as her hemoglobin is also starting to normalize here. And then you can also see an improvement in her serum creatinine within a week of starting treatment. So it kind of reaches a peak there at the 16, and then it starts to trend back down after a week into the treatment, I'm sorry. So to summarize SM's case, again, she received meningococcal vaccine on the first day of her eculizumab treatment. She did start prophylaxis with azithromycin 500 milligrams daily for 2 weeks. Unfortunately, she wasn't able to use penicillin V due to her penicillin allergy. As I just stated, and as you've seen on the table, we did start to see improvement in hemolysis labs 7 days from the start of treatment. Her renal function returned to baseline, and again, she only required 3 sessions of hemodialysis, and she remained on C5 inhibitor therapy beyond 6 months, and she tested positive for a genetic screen showing increased risk of CMHUS. And so like I mentioned in the beginning, majority of these patients, or a good amount of these patients, do have a genetic mutation of their complement system. Moving to price considerations, so for eculizumab, for your 300 milligram per 30 ml vial, it is roughly $6,500. And then for ravulizumab, for the 300 milligram and 30 ml vial, it is roughly around the same, $6,400. And then your 1100 milligram per 11 ml vial is around $24,000. And so as you can see here, for your treatment costs for like a 6-month duration, your treatment cost for a 6-month duration for your eculizumab is $340,000, and then for ravulizumab, it's close to $270,000. So as you can see, these medications are pretty pricey. Both of them are, but I would think we would rather use ravulizumab, not only for patient adherence because it's dosed every 8 weeks in the maintenance phase, but also overall for the 6-month total duration. It is less than the eculizumab. Still high, but still less. So that brings me to my take-home points that I would like you guys to remember. CMHUS is a complement-mediated disorder that can be triggered by pregnancy. Other TMAs with similar presentations, so such as TTP, STHUS, and other secondary causes must be ruled out prior to the diagnosis of this disease state. Majority of these patients will present with severe renal failure. And lastly, C5 inhibitors are the treatment of choice for pregnancy-associated CMHUS. And that concludes my presentation. Do y'all have any questions? That's a good question. From what I read, I believe it's anytime within the postpartum phase. Like I've seen some patients up to like maybe a month or two out also. But with hers was rather quickly. That's it. Yeah. Yeah. Mhm.
When should they know that the man decides that not to belong?
I would. Hmm. Honestly, that's a good question. I would have to look into that because once you're postpartum, you could be having a lot going on. So it might be hard to tell. Um, I don't know, but I could imagine. It would probably be hard to tell. Is this like your typical postpartum presentation? So that is something definitely to look at. But do they get follow-up appointments for like?
Yeah, follow up, yeah, 6 weeks later.
Mm,
Correct, yeah, I did not get that.
okay, interesting.
Like, that's what I'm saying, like, you wouldn't know, like, I wouldn't know.
Right. Mm-hmm. Oh, I'm sorry, Gina. Kristen asked if, how would these patients know, if they were experiencing this? Like, how would they know based on if they were just having nausea and vomiting or headache or anything? How would they know to present to their doctor's office? So I told her I can see how that may be difficult because postpartum, you're probably experiencing a lot of emotions and other things as well. So I know that could be difficult. So I'll have to look into that because our patient did present with just like nausea and vomiting and abdominal pain.
Sounds like they caught it early too, because this can lead to stroke, heart attacks.
Right. Mm-hmm. Yes, I believe they did. So like I said, this was a 30-year retrospective study. So like the other 12 patients, I believe they just received like plasma therapy, which is not what you would want to give these patients. That's typically, I believe, what you would treat with like TTP. And so I don't believe they compared them actually, but the other 10 patients just received plasma therapy and then they went based off their primary incomes, like how long it took them to achieve these responses and things of that such.
How long did they follow them?
It's a 30-year retrospective study. Yeah. Yeah. This study was also done in Spain. So yeah. Yes, they defined end-stage renal disease as the need of renal replacement therapy such as dialysis or transplantation. But I didn't see a time that was specified, but that's how they defined it. Okay. You're welcome. Yes. That is a good question. I will have to get back to you on that one. The E. coli. It would kill all the other healthy bacteria as well. You think it would be resistant? Okay. I'm sorry, Gina, the question was, why do you think for Shiga toxin HUS that it isn't treated with antibiotics? What's the question that was asked? Yes.
So I'm working. Yeah.
Yeah.
What do I do? Why? What is essentially what we do here? Is this?
It isn't chemo. The question that was asked was, once a patient comes in and they gets all these labs done and stuff, does this happen inpatient? And I answered yes. And then you asked, what would you do?
I'm assuming you're getting like $8,000,
Mm-hmm.
because it's that first dose.
Right. I'm not sure, but I know for her specifically, so they got the Adams TS 13 done, and then that came back 3 days later, and then they started the treatment. But I know like in between then she was getting like blood transfusions and things like that. And so I think they were just managing her like supportively up until they were able to confirm and then order it. Yeah, right. Right. Yes, because you have to exclude all the other things, because it could be, yeah, right. Especially with the Adam TS. I think here we sent it out to the Mayo Clinic, and that came back 3 days later, so.
Yeah. Hey, I don't know if can y'all hear me?
Yes, we can hear you. I'm sorry.
Okay, sorry, Taylor may have said this in the room, but yeah, so exactly what you said, Jerry Ann. So because the turnaround time on the Adams CS13 is pretty laggy here, what you'll do is you'll initially treat like it's TTP, and so you'll start plasmapheresis, you start steroids, and you send off the Adams CS13, and then once that comes back, if you rule it out, you stop plasmapheresis and you pivot and get your diagnosis of what else is going on causing the TMA. If that helps.
Thanks, Casey. Yeah, you have a little time. Okay. Were there any other questions? Did anybody else have questions on Zoom?
I had a question. Great job. Are the biosimilars, have they been priced yet?
They have not, but I'm glad that you brought that up, because as you can see, the prices of these medications are really expensive, but with those biosimilars coming out, you can expect to see some competition. So hopefully like in the next couple of years, we'll probably see these prices decrease with the biosimilars that are coming out because of the competition. But I have not seen any prices as of right now, Casey.
Yeah, I love that. Yeah, they're not out yet. Good assessment. And then why do you think that like these two, eculizumab and ravulizumab, like their competition hasn't seemed to decrease pricing yet? Because they're doing the same thing.
Because these two medications are owned by the same manufacturer.
Yeah.
Mhm. Mhm. Yes, so basically like okay, so what was asked is with the RIMS program and how that works. So, so basically the provider has to be signed up, and then once they send us the prescription, before we can even order the medication, we have to send all this information to the company. So we have to send them the patient's name, their date of birth, the prescriber, and then they'll be like, okay, we'll send it out to you. And then, so that could also be, but hopefully they'll send it rather quickly considering. Yes, they have a similar RINs program. It's just because it's a different manufacturer, they have to have their own. And then, Gina asked, how quickly would you expect to see lab and symptom improvement? So you, like I said, with our patient SM, you started to see improvement within 7 days of starting her eculizumab treatment. So like around the time she got her second dose. So I would say within like 1 to 2 weeks, you will start to see improvement. And you kind of seen improvement with hers. Let me see if I can go back. So yes, so like around this 1 week mark, you can see, like I said, her creatinine like reached like a peak and then it started trending back down. Her LDH is trending down. Her hemoglobin is starting to normalize as well as her platelet count. So I would say 1 to 2 weeks. It's okay. The yeah, you'll do the 4 and then you'll also do the serogroup B. Yeah. Yes. No. And no. And what was asked here in person is that about the meningococcal vaccines, if a person has already had their standard like child to adult vaccine series, would they have to get it again? And my answer was no, they would not have to. So our patient happened to not be vaccinated, unfortunately. So she had to be treated with prophylaxis. What's your question? You have a question? So you can use Cipro or azithromycin. And the question was, what can you use if your patient is allergic to penicillin? If they have a true penicillin allergy, you can use azithromycin or a Cipro. That is a really good question. Maybe challenge the penicillin allergy if it's a real allergy. And then from there, I will have to see what we could do further. Thanks. The answer was, what if they had a high QTC, if they had a penicillin allergy, and if we used azithromycin or Cipro, if they had a high QTC? Any further questions? All right, thank you all for coming. Good afternoon, everyone. It's 2 o'clock, so we'll go ahead and get started. My name is Jerian White, and I am a PGY1 pharmacy resident here at Ochsner LSU Health Shreveport. And my presentation is Bump in the Road, Exploring Pregnancy-Associated Complement-Mediated Hemolytic Uremic Syndrome. As far as disclosures go, I have nothing to disclose in regards to this presentation. For objectives for pharmacists, by the end of this presentation, you should be able to review the pathophysiology of thrombotic microangiopathy, or TMA, distinguish complement-mediated hemolytic uremic syndrome, or CMHUS, from other TMAs with similar clinical presentations, be able to recognize signs and symptoms of pregnancy-associated CMHUS, as well as discuss management and treatment for pregnancy-associated CMHUS. For pharmacy technicians, you should be able to describe the symptoms of CMHUS, recall how pregnancy can trigger and exacerbate CMHUS, and lastly, be able to list the medications used in the management and treatment of pregnancy-associated CMHUS. We'll go ahead and get started with a brief overview of CMHUS. So what is CMHUS? It is a type of thrombotic microangiopathy that can occur during pregnancy and postpartum. It was formerly known as atypical HUS or AHUS. So if you hear me use these abbreviations throughout the PowerPoint, I may use them interchangeably. It's because this change has been fairly recent. For CMHUS, there are 3 major components. So a patient with this disease state will present with severe renal failure, as well as hemolysis and thrombocytopenia. I would like to emphasize that TMAs are a medical emergency and they can lead to death if they are not treated. For TMAs, you will have some characteristics of microangiopathic hemolytic anemia. And for those, these labs you would see increased LDH, indirect bilirubin, as well as reticulocytes, as well as decreased haptoglobin. In these patients, you will also find that they will present with thrombocytopenia, and this is because your platelets are aggregating and clumping together in these tiny clots in your small vessels. And overall, because of this, this can lead to ischemic and organ damage. So I just mentioned that those little microclots that are in your vasculature is going to cause ischemic and organ damage. So you can think of all your systems that have vasculature. So in addition to your severe renal dysfunction, you can also experience cardiovascular complications such as MI and VTE. You can experience GI complications and neurological complications such as stroke and seizures, as well as pulmonary and vision complications. So I just mentioned that your platelets are clumping together and they're forming these tiny clots in your microvasculature. And so because of this, your blood cells are getting hung up on these tiny clots, and they're having a hard time flowing through these. And so eventually your red blood cells will start shearing and forming what is seen here on the slide. These are called schistocytes. And schistocytes are a nonspecific indicator of hemolysis, and these can be seen in other disease states. So you can see these in patients with mechanical heart valves, hematologic malignancies, patients on dialysis, cancer patients, as well as neonates. Moving back to CMHUS and its pathophysiology. So with CMHUS, what's going on is that there's a dysfunction in your complement cascade. Your complement system is a part of the innate immune system, which is your body's first line of defense against pathogens. As you can see here, the complement system is made up of 3 pathways: the classical, the lectin, and alternative pathway. So in a normal patient, your alternative pathway is maintaining a low level of activity. In a patient with CMHUS, there's going to be an uncontrolled activation of the alternative pathway. And because of this, there's going to be an overamplification of your immune response. Overall, this will lead to clots being formed in the small vessels again all over your body. Moving on to epidemiology, the estimated incidence of CMHUS is 1 to 2 cases per million per year, so very rare. Around 50 to 70% of these diagnoses are caused by a genetic mutation in the complement system. More than 50% of these patients will proceed to end-stage renal failure or death if they aren't adequately treated. And around 70% of initial presentations are associated with triggers. Speaking of triggers, I have a few listed here on the slide. So CMHUS can be caused by inflammation, medications, which I will go into later, as well as cancer, maternal fetal hemorrhage, preeclampsia, infection, family history, and of course, pregnancy, which is what I will be focusing on for today's presentation. Before we move forward, I do have a knowledge check. Which of the following is not a usual presentation of CMHUS? A, hemolysis, B, increase in serum creatinine, C, leukocytosis, or D, thrombocytopenia? And y'all are correct, it is C. So like I said in the beginning, there you have your big three. You're gonna have hemolysis, as well as severe renal dysfunction and thrombocytopenia. Now we will get into pregnancy-associated CMHUS. The diagnosis of pregnancy-associated CMHUS is a diagnosis of exclusion, so it relies on excluding other conditions with similar presentations. Unfortunately, there is no universally available biomarker, and this disease state does typically present postpartum. As I just mentioned, this is a diagnosis of exclusion. So under TMAs, I have other similar presentations that you will want to rule out before you can confirm that your patient has CMHUS. And first, we will be going over thrombotic thrombocytopenic purpura, or TTP. TTP is caused by a deficiency in your ADAMTS13 enzyme, and this enzyme is responsible for regulating blood clotting. It works by cleaving ultra-large von Willebrand factor multimers into smaller multimers, and so when you have a deficiency in this enzyme, as you can see, it's not going to be cutting those into the shorter chains, and eventually this is going to lead to thrombosis. So to diagnose TTP, you're going to get that ADAMTS13 enzyme, and if your activity comes back with less than 10%, then you can confirm that your patient is in fact deficient in this enzyme, and you can confirm that they have TTP. So moving on back to our diagram, once we've ruled out TTP, let's say your patient's enzyme activity level is higher than 10%, they're not going to be deficient, so we'll have to look into other causes such as secondary causes. So here I have a list of a few secondary causes of TMAs. For the purpose of our presentation, I will be focusing on HELP syndrome, or hemolysis, elevated liver enzymes, and low platelet count syndrome. And that's because this one specifically can occur during pregnancy and postpartum, and is often misconstrued with AHUS. But for completeness state, it can also be caused by preeclampsia, autoimmune diseases, malignant hypertension, infections, excluding Shiga toxin-mediated HUS, which I will be getting into as well as medications such as quinine, antimicrobials such as Bactrim and Citro, chemotherapy agents, immunosuppressants, as well as drugs of abuse such as ecstasy and cocaine. So that brings me to a study that looked at HELP syndrome versus AHUS in the postpartum period and comparing their presentations. So with HELP, like it says in the name, you're gonna experience elevated liver enzymes. You can experience those in AHUS, however, it's not gonna be severely elevated as it would be in HELP. Another thing with HELP is that your symptoms will typically improve within 3 to 4 days postpartum, so after delivering the baby. In AHUS, your symptoms are typically gonna progress to severe renal dysfunction. So again, if it's not treated properly, that's where it's going to end up. So having the baby isn't going to necessarily help you with this disease state. So overall, this study found that severe elevation in serum creatinine, so serum creatinine 1.9 or higher, as well as LDH 1832 or higher, you can confirm that those are specific to AHUS. So once we've ruled out TTP as well as secondary causes of TMA such as HELP with persistent severe renal dysfunction, we can look at STHUS. Shiga toxin-mediated HUS is also known as typical HUS, and so this is going to present with a GI infection, and this infection is caused by Shiga toxin-producing E. coli. Typically, your patients will present with severe diarrhea, and so to diagnose this disease state, you would look at E. coli isolates and/or Shiga toxin detection in the stool. And so I know we may assume that you can treat this with antibiotics because of the E. coli. However, this disease state is managed with supportive care. So once we've ruled out TTP, secondary causes of TMA such as HELP, as well as Shiga toxin-mediated HUS, we can look into CMHUS. Going into the epidemiology of this disease state, it occurs in 1 in every 25,000 pregnancies. Up to 20% of CMHUS diagnoses are triggered by pregnancy, and 80% of these diagnoses occur postpartum. Moving into clinical presentation, so your patient will present with severe renal dysfunction, thrombocytopenia, hypertension, nausea and vomiting, as well as abdominal pain. So that brings me to a case presentation. We have SM, who is a 19-year-old female who was admitted to the labor unit for delivery on February 14th. 2 days later, on the 16th, she was able to deliver her baby via C-section with no complications. And eventually, she was discharged 4 days later on the 20th. However, at the time, she was experiencing intermittent hypertension as well as nausea postpartum. She presented to the clinic, to her OB clinic on the next day, and she came with complaints of nausea, headache, as well as shortness of breath. And so they decided to do some labs on her, and her labs, she presented with concerning CBC as well as a CMP. And so because of this, her OB had her readmitted to the hospital for a suspicion of HELP. So as you can see here, I have her lab values during admission. So on the 15th, before she gave birth, they're pretty normal, nothing screaming at you. And then she gave birth on the 16th. Now, once she presented back for her follow-up appointment on the 21st, you can see that her labs are starting to look abnormal. So for her hemoglobin, it is low, and so one might think she could be having some type of hemorrhage. However, she also has signs of hemolysis. So as you can see here with her LDH, it is severely elevated. It's close to 4,000. And then you can also see that she has a high reticulocyte count as well as low haptoglobin. In addition to these hemolysis markers, you can see that her platelet count is extremely low. It's at 13. It was just at 257 a few days prior. So she is definitely experiencing thrombocytopenia. And also, this is probably what jumps at you the most is the trend in her serum creatinine. So you can see before she gave birth, her baseline was about 0.9. And then once she presented on the 21st, it was increased to 4.4, and then it persistently continued to increase throughout her admission. Another thing to note here is that you can see she was running a little hypertensive, so it's not too crazy, but in comparison to her typical baseline, the 120/78, she is hypertensive. And also you can see, as I mentioned before, with the schistocytes are a non-specific indicator. However, once you look at the schistocytes in combination with these abnormal lab values, it's also very confirmative of CMHUS. So let's go back to our diagram and our diagnosis of exclusion for her. So first, we want to exclude the TTP. So they were able to get an ADAM TS13 enzyme test, and as you can see, it is well over 10%. So it's safe to say she is not deficient in that enzyme, and so they were able to rule out TTP. Next, for secondary causes of TMAs, such as HELP, with HELP, again, you will see some severe liver dysfunction. She was having minimal liver dysfunction and very persistent severe renal dysfunction. And so it continued to persist despite everything. So we were able to rule that out. Moving on to the Shiga toxin HUS, unfortunately, this patient didn't have any diarrhea to collect stool culture for this test. But again, with the Shiga toxin HUS, your patient is typically going to present with a bunch of diarrhea, and she didn't have any. And so once they were able to get that lab back for the ADAM TS13 with the 72%, they were able to confirm her diagnosis on the 24th with the CMHUS. Now that we've seen a patient with this disease state, let's look into how we would treat them. As I mentioned prior, this disease state is caused by a dysfunction in your complement system. So of course, we're going to treat it with anti-complement therapy such as C5 inhibitors. And the way these C5 inhibitors work is that they bind to the complement protein C5, which will prevent the cleavage of C5 into C5a and B, and this will in turn inhibit the formation of the complex C5b9, and overall, this is going to prevent CMHUS. So as you can see here, I have eculizumab and ravulizumab on the slide. These are our two C5 inhibitors on the market. So again, for my visual learners, as you can see, it works by inhibiting your C5 enzyme, which again is going to prevent that cleavage from the C5a to the C5b and that conflicts, and it overall is going to prevent your CMHUS. With anti-complement therapy, you can experience some side effects. I will not be going into every single one of them, but I would like to mention that up to 50% of patients that on this therapy will experience headache, up to 35% of these patients will experience anemia, and up to 40% of these patients will experience upper respiratory tract infections. Moving on to warnings and precautions. So it does have a warning for life-threatening meningococcal infections, as well as increased risk of other infections and infusion reactions. So that brings me to the box warning. So these complement inhibitors do increase the risk of fatal meningococcal infections. And because of this, patients must receive their complete meningococcal vaccine series at least 2 weeks prior to the start of anti-complement therapy. And you're going to make sure that they're getting their serogroups A, C, W, and Y, as well as serogroup B. That brings me to my next knowledge check. Patients may not start anti-complement therapy until they have completed the meningococcal vaccine series. True or false? Anyone out here? True. And it is false, and I will tell you why. So if a patient hasn't been able to receive their meningococcal vaccine series 2 weeks prior to the start of treatment, we wouldn't want to delay therapy because again, this is a medical emergency, so we wouldn't want to do that. We would still go ahead and treat them, and we will also give them their vaccines once they start treatment. And because of the increased risk of meningococcal infections, we will also give them antibiotic prophylaxis. So the most preferred antibiotic for prophylaxis is penicillin V, 500 milligrams oral, twice daily. Some studies may suggest using amoxicillin as well as azithromycin or Cipro if they happen to have a true penicillin allergy. You would want to continue this antibiotic prophylaxis until 2 weeks following the completion of the vaccine series. But however, some providers may choose to continue this prophylaxis in addition to vaccination for the duration of complement inhibitor therapy. Because of the increased risk of fatal meningococcal infections, that brings me to the REMS program for eculizumab and ravulizumab. And they have a joint REMS program because both of these medications are owned by the same company. For this REMS program, providers must become certified to prescribe. For pharmacies and healthcare settings, we must be certified to dispense, and we can't even just order the medication like just straight out the gate. Once you've received a prescription for this medication for a patient from a prescriber, you must send the company the patient's name, their date of birth, as well as the prescriber's name before the company will even ship it out to us for us to be able to stock it. So it's very patient specific. Also, we must assess the patient's vaccination status for up-to-date vaccines, as well as assess to see if they are on antibiotic prophylaxis if need be. And as pharmacists, we should be able to document this. And lastly, we must obtain authorization for dispensing the first dose 6 months after the first dose and thereafter. That brings me to our first C5 inhibitor, eculizumab, or brand name Soliris. For eculizumab, for the dosing, there is an induction phase as well as a maintenance phase. For your induction phase, you would give your patient 900 milligrams IV weekly for 4 doses, so for the first 4 weeks, and then you would move into your maintenance phase at week 5 with 1.2 grams IV, and then you would proceed to give them that same dose every 2 weeks after. And one thing to note with eculizumab is that it is infused over 35 minutes. For eculizumab, there has been some FDA-approved biosimilars. So first I have Episcli, which has been approved earlier this year in July. And so because it has a different manufacturer, it does have its own separate REMS program. And then next we have Bekinvi. This one was also approved earlier this year in May. And again, it does have a different manufacturer, so it does have its separate REMS program. And one thing to note with Bekinvi is that it is interchangeable. So basically what this means is that if you were to receive a prescription for eculizumab and you didn't have the regular generic on your shelf, but you happen to have this biosimilar on your shelf, you'll be able to change it out and dispense this one instead without even having to reach out to the provider and ask for approval to change it. Moving on to eculizumab and its use in pregnancy and postpartum. Unfortunately, eculizumab does cross the placenta. However, it is detected in low levels, so there is no effect on neonatal complement activation. As far as breastfeeding goes, there are also undetectable levels in breast milk. So overall, there have not been any adverse effects reported in neonates. That brings me to a retrospective study that looked at the use of this medication in patients with pregnancy-associated AHUS. This is a 30-year retrospective study, so this is before Soliris was even approved on the market, because Soliris came to the market in the US and European markets in 2007, so that is also something to keep in mind. They looked at 22 patients total who presented with this disease state, and of those 22 patients, 10 of them were treated with eculizumab for treatment. For primary outcomes, they looked at hematologic as well as renal responses, and they defined hematologic response as the normalization of platelet count and disappearance of all markers in microangiopathic hemolytic anemia. They also defined renal response as the recovery of renal function, 25% or more reduction in serum creatinine levels in 2 consecutive measurements for 4 or more weeks. For secondary outcomes, they looked at end-stage renal disease diagnosis, and they defined that as the need of renal replacement therapy, whether it was with dialysis or transplantation. As far as the results go, of the 10 patients that received eculizumab, all of them achieved hematologic and renal response. 30% of them required dialysis initially, however, they were able to improve as far as their renal function goes, and none of them reached end-stage renal disease diagnosis. Overall, the study concluded that eculizumab was shown to be effective in reversing severe renal dysfunction prognosis in this disease state. That brings me to our next C5 inhibitor, ravulizumab, or brand name Ultomiris. One thing to note with Ultomiris is that you can see here on the slide, it does come in 2 different vial sizes. It comes in a 300 milligram vial as well as a 1100 milligram vial. And other than that, it is very long acting, so its half-life is around 52 days. And so because of this, it does have a less frequent dosing in comparison to eculizumab, which I will go into. And then also, there is weight-based dosing with this medication. So for dosing for this medication, it is similar to eculizumab in the sense that it does have an induction and maintenance phase. So for your induction phase, of course, you're going to get a one-time loading dose. And then for the maintenance phase, it's going to be dosed every 8 weeks, starting 2 weeks after that loading dose. So again, because of that very long half-life, there is a less frequent dosing. I did mention that there is weight-based dosing. So let's say you have your average patient that weighs around 80 kilos, you would load them with a 2,700 milligram loading dose, and then 2 weeks later, you would follow with a 3,300 milligram maintenance dose, and that would be every 8 weeks moving forward. For ravulizumab and its use in pregnancy and postpartum, unfortunately, there is not a lot of clinical data on its use in pregnancy or postpartum. However, there are current ongoing recruitment for future studies. That brings me to our next study, and it looked at ravulizumab in the use of these patients with this disease state presenting postpartum. So this was a phase 3 single-arm multicenter study, and it looked at 8 patients total with pregnancy-associated CMHUS who were treated with this medication. For the primary outcome, they looked at the complete TMA response through an initial evaluation period of 183 days, and they defined this TMA response as platelet count normalization, LDH normalization, and 25% or greater improvement in serum creatinine from baseline. For secondary outcomes, they looked at the time to complete TMA response, change in hematologic variables such as platelets, LDH, and hemoglobin, change in eGFR, as well as the dialysis requirement status. As far as results go, 7 out of the 8 patients did achieve TMA response. For the 1 patient that didn't achieve TMA response within that time period, they were able to achieve the TMA response on day 8. So overall, this study found that ravulizumab was shown to be safe and effective in women presenting with this disease state postpartum. That brings me to our last and final knowledge check. Which C5 inhibitor has a longer half-life and is dosed every 8 weeks during the maintenance phase? Y'all are correct, it is A. So again, this is the one that has the longer half-life, that is around 52 days, and because of that, it is dosed less frequently. Now that we've looked at treatment, we can go back to our patient SM. And so these are her labs when she started treatment. So on the 24th, she did receive eculizumab, starting her induction phase of that dosing. She also started her meningococcal vaccine series on this same day because unfortunately she wasn't already vaccinated. And then in addition to that, she did receive hemodialysis on the 1st and the 2nd, as well as the 5th, which isn't shown here. So as you can see here, she started it on the 24th, excuse me, and then within a weekend, you can start seeing some of her lab values are normalizing. So as you can see, her hemoglobin is starting to normalize. Again, on the 21st, her hemoglobin was 5.5. Next, you can also see that her platelets are starting to trend back upwards. So again, on the 21st, when she presented, they were at 13, and now they're improving. And so again, maybe around that 1 week mark, you can see like a week after she started eculizumab is where you're starting to see improvement into her lab values. Also, you can see her serum creatinine, so it continued to increase, and then around that 1 week mark, it reached a peak, and then it's starting to decrease, as you can see there. And lastly, you can see that her LDH is also continuing to trend down as well. So to summarize SM's case is that she received the meningococcal vaccine again on the first day of her eculizumab treatment. She did start with prophylaxis with azithromycin, 500 milligrams daily for 2 weeks. And this is because she had a reported penicillin allergy, so we weren't able to use the penicillin V. Again, as I mentioned prior with the table, you can see an improvement in her hemolysis labs within 7 days from the start of treatment. Her renal function did return to baseline, and she only required 3 sessions of hemodialysis. And she has remained on C5 inhibitor therapy beyond 6 months and tested positive for a genetic screen showing increased risk of CMHUS. And remember in the beginning, I did state that majority of these patients, or a good amount of these patients, will present with some type of genetic mutation of the complement system. Moving on to price considerations, so starting with eculizumab with its 300 milligram per 30 ml vial, it is around $6,500. And so once you're looking at the total treatment cost for like your average treatment duration, which is 6 months, it's close to $340,000, which is not cheap. And then once you look at ravulizumab, for your 300 milligram per 30 ml vial, it is kind of similar to eculizumab. It is $6,400. And then you have your 1,100 milligram per 11 ml vial that is 23 or close to $24,000. And then for a total cost duration for your 6-month duration for like your average patient that's 80 kilos, that is close to $270,000. So still pretty expensive, but it's not as expensive as your total 6-month cost for eculizumab. One thing to note here is that they do have those biosimilars that were approved earlier this year. So with those biosimilars being introduced to the market, you might see some type of competition, and these prices might actually decrease in the next couple of years with those biosimilars coming to market. You might not see like a difference in these prices, and again, that's because these medications are owned by the same manufacturer. So here are some points that I would like you guys to take home with you. CMHUS is a complement-mediated disorder that can be triggered by pregnancy. Other TMAs with similar presentations, so such as TTP, STHUS, and HELP, all must be ruled out prior to the diagnosis of this disease state. Majority of these patients present with severe renal dysfunction. And lastly, C5 inhibitors are your treatment of choice for pregnancy-associated CMHUS. That concludes my presentation. Do you all have any questions? Yes, what's your question?
Can you go back to like the people? This vaccine,
Mhm.
then a couple vaccines given. Is it one vaccine or is it two vaccines?
Yes, so you would get the quadrivalent one with the ACWY, and then you'll also get the serogroup B vaccine as well. Yes, there is. I don't think we carry it here, unfortunately. I think it's the Menatra. Yeah, I'm sorry, for those on Zoom, the question was, for receiving your meningococcal vaccines, would you only receive one vaccine? And so I answered with two. You can get the quadrivalent one with the meningococcal serogroups A, C, W, and Y, as well as serogroup B. And then there is a combination vaccine out there, the Menactra. However, unfortunately, we don't carry the combination one here at this hospital. Unfortunately, I did not look into that for this presentation, but I can take a look into that and get back with you, but I don't know off the top of my head. Mm-hmm. Mm-hmm. Yes, so basically what I've seen is that they will treat it as TTP, and I think the patient might start getting like plasmapheresis and things of of that sort. And then once they get that Atom TS13 back, they'll be like, oh, we don't need to do this. Like, they obviously don't have TTP. And then you would mainly just have to treat with supportive care until you're able to get that drug in. But normally it will come in rather quickly, since this is it's a medical emergency, like I stated, so.
I have a question, and I don't know the answer technically. Do you know why Neisseria meningitis is associated with this medication? Like, I don't know if you read anywhere, it's just because it suppresses your immune system?
Yeah, yes, from all I read, and I'm sorry, the question was, do you know why there's an increased risk of meningococcal infections with these medications? And from what I read is that it's suppressing your immune system. And I think, and it's with all like complement inhibitors, not just these two also, but like all anti-complement therapy. I know the CDC recommends that you get vaccinated or have some type of prophylaxis. Mm-hmm, yeah. I didn't see anything about Haemophilus or Strep pneumo. Were there any questions on Zoom? All right, well, if there aren't any other further questions, then we will conclude this presentation. Thank you all for coming.